the management of acute pancreatitis. Welcome to the Everything Surgery podcast, where we dissect the extraordinary. In today's episode, we are taking an in-depth look at the management of acute pancreatitis, guiding you through each stage from diagnosis to treatment and navigating potential complications. Our goal is to deliver clarity and structure for clinicians, trainees, and anyone interested in medical practice. Overview of acute pancreatitis. Acute pancreatitis is a sudden inflammatory condition affecting the pancreas. Its severity can range from mild, self-limiting illness to a critical condition marked by pancreatic tissue death, multi-organ failure, and significant risk of mortality. While there is no direct medication available to halt the inflammation once it starts, supportive care stands at the forefront of management. This involves robust fluid resuscitation, effective pain relief, and nutritional support, all while keeping a close eye out for any complications that may arise. Diagnosis and assessing risk. The first step in managing acute pancreatitis is prompt diagnosis and evaluating how severe the disease is. Diagnosis typically relies on 2 out of 3 main criteria: abdominal pain that is consistent with pancreatitis, blood tests showing a significant rise in pancreatic enzymes, and imaging studies that reveal characteristic changes in the pancreas. It is also vital to identify those patients who might develop severe disease early on, since this determines whether they need intensive care. Clinical assessment involves looking for signs of widespread inflammation, such as fever, rapid heart rate, quick breathing, and increased white blood cells. Several scoring systems help in predicting severity, including bedside indices and organ failure scoring tools. Laboratory markers like elevated blood urea nitrogen, rising hematocrit, and increased creatinine levels also help in risk stratification. Imaging, particularly contrast-enhanced scans, are reserved for cases where the diagnosis is uncertain or the patient's condition is deteriorating. Initial and supportive management. The initial 24 to 72 hours are crucial and can significantly influence patient outcomes. The first priority is aggressive fluid replacement, using solutions that help maintain blood volume and perfusion to the pancreas, thus reducing the risk of tissue death. The preferred fluids are balanced solutions, and the rate is carefully adjusted to achieve target urine output and stabilize vital signs. Pain management is essential because severe pain is a hallmark of acute pancreatitis. Intravenous opioid medications are considered first-line options and should not be withheld due to outdated concerns. Patient-controlled analgesia can be particularly effective in these cases. Nutrition is another key component. Contrary to earlier beliefs about pancreatic rest, current practice supports early feeding through the digestive tract. This approach helps maintain gut integrity, reduces the risk of infections, and improves outcomes. Tube feeding can be started within the first 24 to 48 hours for those unable to eat, while mild cases can resume a low-fat diet once pain is controlled and appetite returns. For nausea and vomiting, intravenous antiemetics are administered as required to keep the patient comfortable. Identifying and treating the underlying cause. Determining the cause of acute pancreatitis is essential for targeted management. This involves a thorough history, specific blood tests, and imaging studies. For example, elevated liver enzymes may suggest gallstones as the culprit, and ultrasound is the first-line test to detect stones or duct blockages. If gallstones are found, treatment may involve an urgent procedure to remove blockages only if there is evidence of additional infection or persistent obstruction. Surgery to remove the gallbladder is recommended during the same hospital stay, once the pancreatitis has settled, to prevent future episodes. Managing complications and severe disease. Severe acute pancreatitis often necessitates care in an intensive setting. Local complications such as fluid collections around the pancreas typically resolve on their own, but persistent or symptomatic collections may require further intervention. Pancreatic pseudocysts, which are defined fluid collections, are only drained if they cause symptoms, become infected, or obstruct nearby structures. More serious complications include infected pancreatic tissue death, which may present as ongoing fever, worsening condition, or visible signs of infection on imaging. Treatment follows a step-up approach, beginning with antibiotics and minimally invasive drainage and escalating to surgical removal only if necessary. Minimally invasive methods are preferred over traditional open surgery. Systemic complications such as organ failure are managed supportively, including mechanical ventilation for breathing difficulties, medications to support blood pressure, and dialysis for kidney failure. Abdominal compartment syndrome is another critical complication, managed with drainage procedures or, in severe cases, surgical decompression. Summary and key points. In summary, the management of acute pancreatitis is a dynamic and multifaceted process. It begins with accurate diagnosis and risk assessment, moves through aggressive supportive care and early nutrition, includes targeted treatment of the underlying cause, and requires vigilant monitoring and intervention for complications. Avoid using antibiotics routinely except for proven infections. Refrain from unnecessary feeding through veins, and do not order early imaging unless the patient's condition warrants it. Most importantly, do not withhold adequate pain relief because of unfounded concerns. Thank you for joining us on today's episode. If you found this discussion helpful, please like, share, and hit the subscribe button. Stay tuned for more episodes on the Everything Surgery podcast as we continue to unravel the complexities of surgical care.